A patient was admitted to the emergency department of the Santa Clara Hospital due to activations of the emergency medical service in the Industrias or the city of Bogota. At the time of registration, a 52 years old male patient, unconscious, disoriented in time, place, and persons, was observed of habitations. According to the ambulance personnel and individuals we were citizens, he was worked in the corresponds factory in changes, productions, and changes on fire extinguishers. Additionally, a work said he was lift a bottle of carbon monoxide and lit of very high lighter. The jar the building covered and he lost his the balance a few. I think the view of the skin.
The patient has a history of coronary heart disease, asthma, and recurrent episodes of bronchitis. He has been an active smoker for 2 years. He has been working in a toxic chemical company as a lead smith for 10 years, where there is no adequate supply of personal protective equipment for workers. He has no pharmacology management according to these recurrent pathologies. Physical assessment of the patient's showed vital signs: 90 systolic over 60 diastolic millimeters of mercury, heart rate 150 beats per minute, respiratory rate 10 breaths per minute, temperature 34 degrees Celsius, oxygen saturation 85%, weight 65 kilograms, height 1.17 centimeters, Glasgow scale 7 of 15, pediatric pupils of 5 millimeters, pale skin with capillary filling for second, chest with signs of respiratory distress with evidence of accessory muscles, barrel chest raised on auscultation, abdomen soft depressible globes, lower limbs with press of grade 3 varicose veins, a rhythmic pulse, slow capillary filling less than 4 seconds. The intravenous line was opened with 2 venous access. Immediately to drop in blood pressure, the doctor ordered to manage the hypotension with dose of dopamine at 10 micrograms per kilogram per minute and dobutamine at 2.5 micrograms per kilogram per minute. At the moment, there was no improvement.
In case of suspicion of intoxication by chemical substance, including lead and carbon monoxide, the following tests are performed which yield the following results: carboxyhemoglobin 10%, lead in blood 45 micrograms, electrocardiograms alteration of the EST segment supraelevation and longer duration of the QT interval. All of the exposure markers greater than or equal to 100 micrograms per deciliter. Chest X-ray indicates the presence of pulmonary emphysema. Hemogram pretrombin of 13 seconds, slightly prolonged and activate partial thromboplastin time of 36 seconds with thrombocytopenia of 149,000 cubic millimeters, D-dimer 6,100 nanograms, and fibrinogen of 40 grams per liter, and hemoglobin was normal 17 grams.
Taking into account the above, it is decided to give strict surveillance to the patient in the observation unit. Later, the patient is intubated due to signs of recurrent respiratory distress and altered state of consciousness, for which a dose of midazolam, sedative analgesia, is administered, 13 milligrams per kilogram per hour, and fentanyl 113 micrograms per kilogram per hour. Start airway mask, ventilation, heart rate increased to 220 beats per minute, with possible suspicion of paroxysmal ventricular tachycardia managed with intravenous bolus adenosine at 3 milligrams.
Due to the rapid alteration of the cardiac rhythm on the monitor evidenced by a pulseless ventricular tachycardia, the physician quickly gave a verbal order to proceed to defibrillate with 3 shocks and administered a mere around 300 milligrams. A response of the cardiac rhythm is obtained 2 minutes after the administration when the blood pressure is evaluated at 70 over 60 millimeters of mercury. Therefore, the immediate management is given with adrenaline 0.65 milligrams over kilograms. Patient achieved stabilization of his vital signs and was left in the intensive care unit, maintaining vital signs of 100 over 75 millimeters of mercury, heart rate 60 beats per minute with mechanical ventilation with high flow venturi device at 35%.
The patient vital signs were stable and the patient Phoenix condition was evaluation slowing hematomas and edema in the lower limbs. So disseminated intravascular coagulation of a low evaluation was determined and prophylactic management with heparin 5000 or intravascular every 4 hours until pronem. Upon analyzing the elimination part of the subject of Carro, an alteration of the same is evident, so we proceed to perform renal function detection test. We share the following result. Boom, 25 mg for deciliter. Creatinine, 3 mg for deciliter. Before and the key renal lesion which seen for urinary restate indefinite. Therefore, intravenous furosemide 40 mg started which implies of the menace of prepol edema may lead in the lower limbs.
The patient remained stable for approximately 2 hours. However, the nursing assistant immediately reported neurological change manifested by the onset of a convulsive crisis that lasts approximately 40 seconds. A dose of diazepam 20 milligrams per kilogram was immediately administered by verbal medical order.
After 2 hours of close monitoring and control in the intensive care unit, vital signs were evaluated: blood pressure systolic of 19 over and 17 millimeters of mercury and diastolic, heart rate of 15.6 beats per minute, respiratory rate of 27 breaths per minute, and temperature 13.4 degrees Celsius. In the cecal examination were the evidence of disease distal perforations. When calculated in the urinary output is found 0.3 millimeters over kilograms per hour. So it suggests to take arterial blood gasometric summing on volume ballots. Hydrogen potential 7.2. Carbonate D6 preserve 25 milliliters of mercury beaker. Bicarbonate 14 millimeters of mercury. Oxygen pursued 65%. The above is possible indication of descompensated metabolic acidosis. Therefore, 113 milliequivalents per kilogram of sodium bicarbonate is performed of 4 hours on until change of evidence.
1 hour later, the respiratory therapist indicated that there was an improvement in the respiratory pattern. However, upon evaluation, there was evidence of overexertion of the use of accessory muscles and exacerbation of asthma. Therefore, it was suggested that a bronchodilator isoproterenol 0.0 milligrams in continuous infusion should be started to relax the bronchial muscles. Patient remains stable to 45 minutes after respiratory therapy, followed by control of vital signs, blood pressure, 18 systolic over 60 millimeters of mercury diastolic, heart rate 30 beats per minute, respiratory rate 10 beats per minute. Therefore, code blue is activated. Starting chest compressions and immediate administrations of atropine 1 milligram. The patient stabilizes. However, strict control of the electrical activity of the heart is suggested due to possible suggestive abnormalities linked to previous intoxication.
When the vital signs were re-evaluated, blood pressure was found to be 200 systole over 100 diastole measured for mercury. Before nitroglycerin 5 units per ml was started in the phase on the hypertension crisis. In addition to the above, the following tracing in the descent in the electrocardiogram monitor mainly related to structural already and the cardio level. Therefore, in the sugar to immediately start the management to hydroxine 0.5 milligrams intravenous because the point present paroxysmal supraventricular decam whose function is to inhibit the sodium-potassium, a membrana protein that regulates the flow of sodium and potassium in cardiac cells. Finally, the person stabilized and after about 15 days, he is discharged to hospitalization where the clinical demonstration will be for a cardiovascular rehabilitation will be performed.